Hi, Dr. Lackner, and welcome to the GI Health Summit. Thank you so much for being here.
Thank you for having me.
It's my pleasure. Could you please tell me what it is you do to help people with their GI health?
Sure. Well, I'm a professor in the Department of Medicine at the University at Buffalo School of Medicine, and I'm the director of the Behavioral Medicine Division. The goal of the Behavioral Medicine Division is, in part, to do research on behavioral self-management treatments for IBS and other types of centralized pain disorders that are very difficult to treat from a pharmacological and dietary rehabilitative perspective. And then we also provide treatments, brief, self-administered, brief treatments that are really designed to teach patients practical, concrete skills for managing their pain that don't simply go away.
You said a centralized pain disorder. I've never heard IBS classified that way.
Okay. Well, so by centralized, if you think of pain, if you have an injury, that's say you cut yourself on a knife. That's a pretty straightforward. You have pain. It's kind of a peripheral injury. There's an injury to the nerve and the nerves and the tissues. And those types of pain problems are pretty straightforward. There is a relationship between how much injury you have and how much pain you have. So a paper cut doesn't hurt as much as if that same finger is broken. And those types of problems go away within, say, 3 to 6 months. Those are acute pain problems. And then with acute pain problems, they're governed to a large extent by the peripheral nervous system. Okay. When pain goes beyond that window, after 6 months, the brain takes a more of a lead on influencing how much pain we have. And when we say central, we're talking about the brain. So we know that problems like IBS, chronic pelvic pain, fibromyalgia, TMJ, those are all very real problems. But they tend to, the intensity of the pain, the severity of the pain, while it's real, seems to have a strong central component. Doesn't mean the person's crazy, doesn't mean they're faking or full of crap. It just means that the balance of influence is disproportionately run by the brain as opposed to other parts of the body. Does that answer your question?
Yeah, absolutely. I just think this is going to be new information to a lot of people because I know so many people with GI disorders in general and IBS in particular. And when they go to their gastroenterologist, they're given some sort of dietary intervention or pharmacological intervention. I don't know anybody that's really been offered a behavioral intervention.
Right. Well, so what happens with centralized problems, it's kind of like, think of it a little bit like a sunburn. I mean, you live in California, so you're used to the sun. But if someone is from, say, Minnesota or Buffalo and has not been in the sun and then comes in the middle of comes to, LA in the middle of the summer, after being outside, you can get a sunburn, right? And if you touch your shoulder after you get a sunburn, it might hurt more than it would normally hurt. Now, that's an example of how the brain and the body interact to sensitize nerves. It's very real pain, but the barrage of pain signals to the brain basically starts sensitizing the pain system. And you can have pain at even lower levels than you would normally have. Sometimes the pain can get triggered even when it's not triggered by things that are not normally painful. So if I touch your shoulder, for example, that's not normally a painful, I mean, I don't know you, so it might be painful if I just start touching your shoulder. But touching a shoulder wouldn't normally be painful. But if your brain is barraged with pain signals, it kind of throws a monkey wrench, and that's what we mean when we talk about centralized pain. It's a very difficult, challenging type of pain, and it's unfortunate that people who have those centralized pain disorders are oftentimes treated as just crazy or whacked out, when in fact they have a really, really complicated problem, not something that's easy to dismiss as, well, you're just too fragile or too sensitive or too crazy.
Yeah, I know a lot of people say they hear that, or too anxious. So how do you work with these patients?
So our approach has evolved over the past 20 years. I think that when we started, behavioral treatments were seen as kind of a treatment that kind of mopped up the emotional unpleasantness of having a chronic illness. And certainly that's the case. I mean, the day-to-day burden of having any type of chronic illness is really challenging. When it's pain, it kind of seeps into every kind of nook and cranny of your life, whether it's work or home, intimacy, self-image, above and beyond just the unpleasantness of the different symptoms. So I think when we started, the view was that behavioral or psychological treatments were just kind of helping someone cope. I think as we have kind of drilled down on and doing more research, we find that, that's true, that behavioral treatments can be effective in helping people manage the emotional unpleasantness of pain and other types of symptoms. But because the way the brain and the body interact, we can actually teach patients to gain control of their symptoms. Sometimes that can be physically, and sometimes that can, through muscle relaxation skills, and sometimes that can be different ways of processing information. And those are the two kind of groups of skills that we focus on. Does that answer your question?
It does, but I'd like to do a little bit more detail. Like, for example, if I was an IBS patient and coming to you, what would you do with me?
So what we, one of the, I'll just tell you a strategy that we kind of developed that will give you, so one thing we know about patients who have IBS is they have what's called what behavioral scientists call a non-discriminative coping style. Now, by a non-discriminative coping style, what that means is that regardless of whether a problem is controllable, they try to fix it. So they kind of lead by preference. So if their friend asks them to, can I get a ride home? Yeah. And that obviously can be stressful, and that stress can kind of disrupt how the brain and gut interact. It's kind of interesting because patients who have functional GI disorders have this kind of this characteristic inflexible coping style, where regardless of the controllability of a problem, they try to fix it. That's different from patients who are healthy controls. And that's actually different from even some other types of medically ill patients. So, the strategy used to be to kind of teach people to just brainstorm their way through problems, or to just kind of positively reframe problems. Like if I think positively, I can do it. Well, you can imagine that if the problem doesn't lie in generating a solution, but there is no solution, that's probably not a good strategy. So the strategy really is to kind of be able to read cues in your environment better, to be able to kind of be more flexible in how you appraise the controllability of your stressor, and then be able to kind of adopt the best coping strategy. So for problems that are controllable, they do what their bread and butter is, right? They solve it, they fix it, they approach, they take action. My sense is we don't really need to teach our patients that. They're pretty good at that. They could probably teach me a little bit. But I think for those problems that are uncontrollable, they can use a little rounding out. So in that situation, they need to be able to kind of learn to kind of, handle the emotional unpleasantness of problems, learn to be able to resign yourself to problems, accept problems, be able to reduce the, apply muscle relaxation skills, enlist support, being able to tolerate distress. Those strategies, those coping skills don't fix problems, but they kind of help people regulate their emotions around difficult problems. So I think I think that's probably the most clearest idea of what we might do. Is that helpful to you?
It's really, and I find it fascinating because I imagine there are probably people even that don't have GI disorders that have inflexible coping styles for whom this kind of treatment might be very useful.
Yeah, I think that's probably true. And I think that, so our approach is to kind of help people process information. It's kind of an information processing approach. I think we also kind of see that our patients kind of make have these cognitive biases. They tend to kind of think the worst and they jump to conclusions. My sense is that that's kind of a way that we kind of exert control. If we can't do anything about a problem, we can at least worry about a problem. And I think the goal is to kind of teach patients practical skills at making sure that when they worry about something, that they can, it generates solutions. It's not just kind of a lever that they activate in response to uncertainty. Because I think that when that happens, the gut kicks in and they then pay a price that way. So I think that it's a set of skills that's helping patients process information more efficiently and more constructively in a way that helps meet their goals without kind of adding to both the cognitive strain and mental and physical strain that can disrupt the brain and gut. Does that help?
No, this is great. If I understand you correctly, being stressed or anxious or having this inflexible coping style, that's not what causes IBS. But once you have it, you can make it worse by worrying and stressing. Is that correct?
Right. So I think one of the, I think that our treatment is as Dr. Meyer has said, is in the New England Journal of Medicine is one of the most, or he wrote, is one of the most effective. And I think one of the reasons among all types of treatments, probably because we don't have really great treatments, but I think think about it a little like high blood pressure. Do you have anyone in your family who has high blood pressure?
Mm-hmm. Yeah.
Who's that?
Well, both my parents had it. Yeah.
Okay. So when your dad went to, when he was diagnosed with high blood pressure, he went to his doctor and he probably was told, you need to do a couple things. You need to watch your diet. You need to be more active. You need to, kind of reduce excessive stress and take this medicine, right? That's probably the first one. Now, he probably didn't say what his daughter just said, which was, whoa, are you saying that, it doesn't cause it, but it can make it? I think there was an understanding that regardless of the cause of a problem, behaviors can affect physiology. So your dad kind of bought into that, and he kind of said, okay, I got to kind of increase my activity level, and I have to kind of lay off the,
The salami.
salami, and I have to take, walks and whatever. And there's kind of acknowledgement that those behaviors alter physiology. I think that's kind of the same model we apply here, which is it doesn't really matter when you have a chronic illness. I mean, our patients in our studies have an average duration of 14 years. So they were not diagnosed yesterday. So after 14 years, it really does not matter. We're not really interested in what causes it, or if we are, we're interested to the extent that it influences what maintains the problem. I mean, flossing doesn't cause the problem I had with my teeth, but it can eliminate the problem. So the same thing is true with, if I wear a seatbelt, it doesn't cause an accident, but it determines how much the impact. So I think that's important to make that distinction is when you're talking about a chronic illness, there's a difference between what causes a problem. That's obviously really important when we're talking about an acute disease, where we can kind of look at what generates the disease and we can reverse that. But when we're talking about a chronic illness, it's much more interactive and reciprocally related and multifactorial. And so the things that our beliefs, our thoughts, our attitudes, and our behaviors, and the environments where we live, those are all kind of ping-ponging back and forth. They don't really care what happens, what caused it. And as pain persists long term, the things that, even when we do know what caused it, the things that make pain persist are they leave those causal factors in the dust. So we know that, for example, the things that as pain persists, we know that the kind of behavioral factors take on a much more of a strong role in influencing pain. How we think about pain, how we react to pain. Those things don't cause it, but they can certainly influence it. And so that's our focus. Is that helpful?
For everything you say is helpful. Do you think the fact that, there was a time that many doctors thought that a lot of these GI issues were all in the patient's head, but the fact that they classify them as functional GI disorders still lets some people, still perpetuates that belief in some people? Well, it was a functional disorder. It's not real.
Yeah, I'm not sure that's really helpful. I think every medical discipline has a functional problem. I mean, neurology has tension headaches, rheumatology has fibromyalgia, dentistry has TMJ, GI has IBS, urology has pelvic pain. I mean, I think that I think it's so common across medical disciplines that it's not really helpful. And I guess when I hear that, the only person that helps is the person who doesn't absolves himself of helping a patient. Okay, so what does that mean? That that it's functional and it doesn't have an underlying physical explanation that corresponds with symptoms. You're still left with a person who's struggling with symptoms. You're still left with distress and impairment. It's actually interesting that we actually don't do that with psychiatric problems, which is interesting. Like with psychiatric problems, we take them for what they are. No one says when to their psychiatrist, when it comes to their psychiatrist, says, well, I can't find a physical explanation. I can't do anything about it. it's ironic that the one area that the medicine doesn't do that with is the one area where they could do it with.
I never thought about it that way,
So,
but you're right.
so I'm not sure that's really helpful. When I did my fellowship, one of the things I remember learning is you take a patient as they are, not as you would like them to be. And a person who comes into our clinic has a set of disorders, a set of symptoms, and you have to kind of make sense of them. I think it's particularly, it's easier to make sense of them if you have a conceptual model that incorporates a lot of different influences. If you only see chronic problems as driven by one, influence, like a biological symptom generator, then it's harder. But maybe the problem isn't the patient, but maybe it's the model that is the bigger problem. Maybe if we kind of expand our model that allows us to accommodate the reality of the patient, it might be easier to kind of talk to the patient, engage them, and motivate them, and optimize outcomes.
I'm writing down some of the things you said about taking the patient as they are, not how as you want them to be. That's like good advice just for everybody in life. I mean, imagine if we just did that with people.
Yeah, I think that's it's great advice. It was one of the best things I learned in my fellowship. I still remember it, and it was not taught by it was taught by I think an exercise physiologist. I remember.
Well, I think acceptance comes into play, because you were saying about the people that have inflexible coping skills, they're not accepting things as they are, and that's part of the problem.
Yeah, I mean, I think that's I'll tell you that I think I think that I think one of that oftentimes these patients are seen as kind of needy. I think if you and demanding and they seeking reassurance. I mean, I think going back to our talk earlier about this kind of rigid coping style, I actually feel like that one of the reasons why we've written an article on this, if you kind of see their need for reassurance as kind of this desire for a fix, then you can then it's not like need. They're just trying to fix something that they don't really understand is not fixable. So if you can get them to kind of appraise their controllability, then it can be really therapeutic. I actually think that one of the things we kind of communicate to our patients is there's two ways, I think, of exerting control in life. One is what you and I probably do. I mean, you have a whole enterprise, you have books and a video and do you podcasts?
Pretty soon, yes.
You podcast. So, I mean, the ability to do all that, it requires an ability to identify a problem and come up with an action plan. And, and so that's kind of the traditional way of being able to exert control. There's another way of exerting control, and that I think is to be able to acknowledge what you can't control. And that's kind of being able to resign yourself and accept that you can't do anything about a problem. And it's always interesting to me how much people feel relief once they stop kind of fighting. They stop picking their battles and stop fighting those things that they can't really do anything about. So I think that ultimately comes down to kind of having a little bit more flexible coping style and problem solving set. Easier said than done, but I think it's important.
It sounds like it would be easier to go through life that way. It made me think of the serenity prayer. God, grant me the ability to change the things that cannot change, to accept. I'm not in AA, but you know the prayer I'm talking about.
So in the book, my book that I wrote, and that's part of our clinical materials, we actually, I mean, that's in the chapter on problem solving. It's actually, I'm Jewish, but the serenity prayer I think is more typically associated with other faiths. But I think it's just an amazing, pithy, it's exactly that. It's being able to kind of align a coping style with your appraisal of control. It's one of the like most awesome sentences in the past 100 years.
Actually, I'm Jewish too, and I have it on a little rock printed. I love that serenity prayer. So how are you getting the patients to do this? Are you using CBT? What modalities are you using to
So
teach
our
them?
approach is cognitive behavior therapy, which I think is one of the the most evident, the most strongly that one of the psychological treatments for which there's the greatest evidence. Over the past 20 years, we've tried a lot of different delivery formats, whether that's individual or group, digital, some hybrid. The one that seems to be the most kind of exciting is this kind of self-administered treatment that includes minimal therapist contact, and most of it emphasizes self-directed learning and kind of in-home learning. I mean, I don't think it's like it's interesting how patients take to it, and it kind of catalyzes behavior change and symptom change in about 60% of our patients. Not everyone gets better. About 40% of patients don't get better, but 60% is pretty dramatic for such a refractory GI disorder, particularly how long patients have had this problem and how few good treatments there are. It's one of the only treatments, CBT, that seems to be effective for the full range of symptoms across different types of bowel types.
Just in case somebody watching this summit isn't familiar with cognitive behavioral therapy, could you just briefly explain what it is?
Sure. So, I think most people it's cognitive behavioral therapy is a psychological treatment. It's probably the most well-researched treatment. The interventions that we described earlier that are the ones we describe as cognitive. And by cognitive, we're talking about changing the way people process information, how they think about things. The assumption is that situations don't really cause us to respond in a certain way. It's really how we respond that drives our reactions. So when we talk solving, or when we talk about getting a handle on excessive worrying, those are cognitive interventions. When we talk about relaxation training, those are designed to kind of change the way people behave, and those are more behavioral interventions. Another behavioral intervention, which I'm very fond of, is simply self-monitoring. I think that those, just being able to track symptoms and to be able to kind of put them in a wider context, being able to kind of step back and say, to shift from this kind of immersive perspective where you're just kind of caught up in the moment with how you're feeling, to kind of stepping back, more of a fly on the wall perspective, is really, really helpful, and can give you kind of the self-reflective legroom that kind of reduces the intensity of reactions, helps you break down things a little more. And so unlike almost every, because we emphasize home-based treatments, we don't like throw a ton of different treatments. Like it's kind of like a cheap European tour. Like if it's Monday, you're in Copenhagen. If it's Sunday, you're in, Barcelona. I think it's our approach is that we try to teach patients to master a certain limited number of skills really well. So we teach them how to monitor. We teach them how to reduce physical tension, to become less reactive. We teach them to get a handle on worry, and we teach them how to problem solve, and some other skills. But those are kind of our core skill set, and I think that patients gravitate to that.
You mentioned that you have some patients that have suffered with IBS for over 14 years. Do you think the duration of their suffering has anything to do with the outcome? Like if they had gotten to you sooner in the diagnosis, might they have a better outcome, or these skills can be applied at any time?
That's a really good question. Obviously, I mean, I'll be honest with you. Not that I haven't been honest with you so far. I had a herniated disc in 2013, and I had it for about 2 weeks, and I was the biggest pussy in that 2 weeks. I mean, I cannot imagine, and I feel like I'm a fairly empathic provider. It was probably one of the best experiences for me, because after, working in this field for 20 years, you kind of like, you get, you lose some empathy. I mean, not you lose empathy, but it becomes more technical. And it was a really good experience for me to be able to kind of reconnect with what patients were experiencing. I'm not sure. I mean, I think obviously we should be seeing patients before 14 years. I mean, that's a long time. That's a long time to just kind of like every day, or with, bowel problems and abdominal pain, and not being able to, go over a bridge, or feeling uncomfortable being intimate with your partner, or, that's a long, long time. And meanwhile, as we talked about earlier, the brain is being barraged with pain signals, and it's just basically getting used to kind of the new normal. And it becomes more difficult, and it's really heartbreaking. I find IBS patients incredibly, I welcome the chance to work with them, because they're honest, straightforward. You know what you're dealing with. There's no bullshit. And they're also there. I think there's going to be challenging patients, but they after 14 years, I think one thing that they appreciate is being validated and respected, and they're really straightforward about what the problem is. And I think that provides a basis for being able to kind of develop a game plan. We see the same patients the physicians see. We find those patients easy to work with. They see those patients and find them a pain in the ass. Something either I don't know. There's something that one of us is doing differently.
That's so interesting. And I'm so impressed with the level of empathy of the experts on this summit, especially since so far none of the experts I've interviewed actually have GI disorders.
Yeah, my family and I were in Toronto during the SARS epidemic in 2002 or 2001, and I had a flare-up of came closest to abdominal pain that was like IBS pain. And I say that because it went away when I had a bowel movement, and that was the closest thing that and I remember it was really painful. And that was like one episode. like I that's not a big issue for me. But obviously in this field, you have to be understanding and sensitive to what it's like. We all have our issues, right? I mean, it's not like, we all, I have epilepsy. My kids have asthma. I mean, we all have, you don't have to have the disorder that your patient comes with to be empathic. If that's the case, you should be not in this field.
Oh boy. Well, with IBS patients, at least the ones I hear from, it's not always so much the pain that is their biggest problem, but for example, those with diarrhea, they have fear, and that they'll be somewhere out in public and they won't be able to find a bathroom. It's not so much pain that's driving them. It's the fear of what if. Or for example, a lot of the women with their IBS, they get visible distension and bloating, and that embarrasses them because people say that they're pregnant. So are you telling me that some of these behavioral therapies can even help with that?
Yeah. I mean, that's what we find. I mean, it's, so what you just said, just think back let's just break down what you just said beyond the symptoms, okay? Because you're focusing on the symptoms. But what you also said is, what if, okay, right? And so that kind of goes back to how we process information. And that fear by our thoughts, our expectations, our cognitive biases. And so if you can teach patients to process information more constructively, then you can dampen that physiological arousal, which disrupts how the brain and gut communicate. So I think your surprise is based on the discrepancy between an outcome and the symptom. But if you look at the mechanism, it makes sense, right? If you look, okay, well, what's driving not so much the symptom, but the fear of a symptom. And that fear is driven by a certain thought. And that thought is a worry, and that worry is a prediction. And that prediction is treated as a fact. But that fact isn't really a fact. That fact is a guess. So the person, I mean, it's always interesting to me that someone who says, I worry I'm going to have an accident, right? That sounds like, I mean, we've heard that all the time, right? That's a prediction, right? That prediction is treated as a fact, right?
Yeah.
You ask most of our patients, how many times have you had an accident? I had one 6 years. How many times have you been to the bathroom?
When you look at it that way, the odds are actually it.
Yeah. Right, but the gut is responding as if it's a definite.
Right.
So it's not to say that you're not going to have an accident, but you want to make sure that you use your brain constructively. And because the brain is kind of like, it's fairly efficient. It's may sometimes take some shortcuts. When it takes shortcuts, it cranks up certain parts of our body that can make pain worse and symptoms worse. So does that help you?
It seems that a lot of people do focus on the worst case scenario and tend to catastrophize their symptoms.
Well, there's every reason in the world why they would. I mean, I can understand that, but the point is that how is that you want to use your brain to help you, not to work against you. And so if that helps, go for it. But it's not constructive. And so you want to be able to and that's where you kind of want to introduce some those emotion-focused strategies like acceptance, resignation, where you're able to tolerate distress better and some of the unpleasantness of things.
It seems to me that if somebody's had IBS for 14 years or any centralized pain disorder or chronic condition, they must be a resilient person. Does resiliency ever play a part in in, in
Well,
helping
I
people?
think that's a really good. I mean, I think that so we've talked a little bit about um, um, thinking the worst. I think the other type of error, cognitive bias that we have is um, kind of an interpretive bias, where you kind of focus on the on on the cost and consequences of a bad event that already did happen. I think that's where certain thinking skills you can teach people to kind of bounce back faster without kind of locking into how bad shit or how bad something really was. Um, and I think resilience, in my view, I think, because again, we have these short-term treatments. My sense of resilience is that it's people being able to activate a certain cognitive skill that allows them to shift gears from focusing on the costs and consequences of a bad event. So again, if you think about people who worry, there's, one is, we want to worry to generate a solution. So if I have an appointment with you, I'm going to make sure, okay, I don't want to be late. And I worry about that. And the other is when you worry about what's going to happen, like, well, what if I can't answer her questions? That's not really helpful at 3:45 because I don't even know what the questions are. And then at 5:05, the other type of worry is if I say, the S word, and I say, geez, I can't believe I said that. If only I had kind of thought. That's kind of like a type of where we're kind of ruminating about an event that has already happened. I think that's what I think of when I think of resilience, is being able to kind of bounce back from that. How do you kind of get someone from not focusing on the costs and consequences and meaning of a bad event, but being able to kind of lock into how do you endure a bad event? How do you get back? And I think there's probably some cognitive or design. Does that make sense?
Yeah, it does. How do people seek this treatment, Dr. Lackner? Because not everybody lives in Buffalo or could travel. Do they need to get a referral from a gastroenterologist first, or can somebody just say, hey, this sounds like a great idea. I'd like to get this kind of
I
treatment?
think there's more. I mean, I think that's a real limitation. One reason why we developed this treatment was to try to make this a more accessible treatment. I think that there's still too few people that are able to do this. I mean, as I said earlier, I think patients of IBS are delightful to work with, and it's really probably one of the most effective behavioral treatments for a pain disorder. There are a number of organizations, Society of Behavioral Medicine, the Association for Behavioral Cognitive Therapies. The Rome Foundation has a roster of providers, and through their psychogastroenterology list, and so there's a growing. I think over the past 10 years, there's a more and more people that are doing this. So does that answer your question?
Yeah. Are you personally doing research in this field? I know you wrote a wonderful paper called Skills Over Pills, a clinical gastroenterologist primer in behavioral therapy for irritable bowel syndrome. And I read it, and it's beyond my pay grade. It's what I could understand was very good. But was there anything that surprised you in this?
Well, it was really designed for the practicing gastroenterologist to try to understand what CBT is, and how it differs from other types of interventions. We're not doing any work we're working, we have one project at UCLA, but right now we're not doing any work. We're interested in other types of pain disorders that are kind of centralized. Right now, that's not where we're focusing on, but if right now, obviously, it's kind of a difficult situation for researchers given the pandemic.
Well, could this treatment be done online, like the way you and I are talking?
There's a number of people that have been approaching it. There's one group in England that did a nice study that was in gut, looking at online treatment, and they got nice results. It's slightly different treatment than ours, I think one of the challenges for online treatments is that they're associated with some, dropout. I think that's a big challenge. That's the challenge, is that online sounds wonderful, right? Because it seems so accessible. But I think that I don't think it's a panacea. And I think that in order for people to get the most out of online treatments, you still need some type of behavioral support to help people kind of troubleshoot around difficulties. But I think that over time, that will be, a more and more powerful treatment. I'm not sure we're there yet, partly because we don't really know what really works. Everyone thinks they know everything, so everyone has their own little pet theory and methods. And I think once people have a better sense of what works, then we can kind of translate those types of interventions to an online platform.
How long does the treatment take? Like, is there a certain number of sessions before somebody finds out if they're going to be the 60% or the 40%?
So that's a great question. The treatment our study had two behavioral treatments. One was meeting every week for 10 weeks. That's kind of a traditional outpatient one-on-one. And the other was largely self-directed in-home learning with only 4 sessions. We saw no change, no difference between each of those conditions. What's interesting is that in that about 30% of people, regardless of whether they come in every week or they get the home-based treatment, about 30% show a rapid response within 4 to 5 weeks. And that's important because that seems to predict long-term gains. And our view is that that being able to kind of, start monitoring, being able to kind of understand how to deconstruct your symptoms, being able to kind of gain control, adopt a different perspective, has a really powerful impact that kind of carries you for a really long time, in about 30%. So, if you think of, we had 60% of about 270 people in the behavioral treatment, that's 60 times, that's 120 people or so that actually got better within a really rapid time. I mean, that's 30% of those. So about 60 of those people got better really, really fast. So that's, I think, how do we explain that? I'm not sure, but I think that there's something about having a really brief treatment that is very catalytic. I think we tend to kind of think that more is better. The more treatment sessions, the longer. I'm not sure that's true.
I'm wondering if I up until I read Dr. Emran Meyer's book, I didn't really know a lot of doctors in general and gastroenterologists in particular that even knew about this type of treatment. Do you think it's becoming more well known so that more people can be referred to it?
Yeah, I mean, I think it's I think it's evidence-based treatment. I think that it's certainly the efficacy profile for CBT is at least as strong as any other medical treatment. The downside is, as you alluded to earlier, we don't have a sufficient number of providers, and so it's not accessible. So we need to do a better job figuring out how to get these treatments so that they help more people in need, or else you just have kind of like it's like a boutique treatment. But I think that compared to where it was 10 years ago, CBT is certainly considered a legitimate option. But it's still, there aren't enough providers that deliver it. And that I think will change, particularly over time.
So if somebody is unfortunate to be in the 40% that doesn't respond, do you have any other tools in your toolkit?
Well, one thing we found in our study, in another study, was that the patients the patients who don't respond to CBT can respond quite well to a really not as well to an education supportive counseling condition. That was kind of our comparison group, but we actually found that if it's a really rigorous patient education supportive psychotherapy, it can be really helpful, and that and many of those people get better in many ways, less pain, improve, decrease symptoms. I don't think the quality response is quite as good as with CBT, but I became a real believer that that you can, particularly for people that are extremely have a lot of like chronic anxiety, who might have a difficult time tolerating the cognitive demands of CBT. I think that a more supportive counseling program would be just fine. I think the other treatment, which we don't do here, is hypnosis, and that's the third treatment that seems to be the one with more with a good evidence base. Again, I think that's there aren't as many providers as the need requires, and I think there's a little bit of a connotation around hypnosis. But I think there's a lot of very good providers, and I think that people in the IBS world who have done a lot of work with that have kind of worked hard and effectively at decreasing the stigma around hypnosis. So I think behavioral treatments are, I think CBT I would recommend as the first, hypnosis, but also being able to kind of learn as much you can and develop a supportive relationship with a therapist who knows, who's familiar with IBS, can actually be incredibly therapeutic.
What about things like, I've heard that acupuncture can help some people. Have you heard that?
I um, uh, am not sufficiently familiar with complementary alternative medicines or approaches, so I'm not going to be really helpful in that.
Okay, just thought I would ask. So, what would you say to somebody that's given up hope? They've suffered with these GI disorders for years. Have you seen miracles?
Well, I mean, so there's two things I would say to that question. I mean, one is that the IBS, like any disorder, is a chronic illness, and so we don't really think in miracles. We think in managing a problem. I think as a behavioral scientist, I would probably kind of and frame it in terms of like, one thing we know is that patients learn to react in a certain way, and that rigidifies over time. That sucks. But the flip side is you can unlearn that. And so if you perspective, then that both explains and provides an opportunity for hope. So that's how I would respond to that.
Yeah. You've said so many gems today, and I'm writing them down. Don't believe in miracles, believe in management. This is life advice, not just IBS advice. It's excellent. Thank you so much. I think part of the problem, Dr. Lackner, is that if somebody's sick, they can go to their GI doctor and get a procedure or a pill, and their insurance will pay. But it's very hard sometimes to get insurance to pay for some of these very helpful treatments. You know what I mean?
I don't agree with that. I think that used to be the case. Yeah, I don't think that's true, and I think that's I think that was the case maybe 20 years ago. I think I think the insurance companies are much more receptive to these types of treatments. I hear that from people who have more of an incentive at pushing, more incentivized around medications, but I don't. We don't have any problem getting authorizations for behavioral treatments from insurance companies. Partly because we invoke, the evidence to support it. 20 years ago, I think, particularly with musculoskeletal problems that were work-related, people didn't want to buy into a stress claim, But I don't think that's true. I think that most insurance companies are forward-thinking. They recognize the literature supporting medications for chronic pain problems sucks. That they're expensive. I think that's been reinforced with the opioid epidemic. Yeah, so but I could be wrong.
Well, I apologize. I stand corrected. It's just I think it might depend on different people's insurance, because this is what I hear from some people when they're seeking.
Yeah, I think that was the case. I've lived in one place for 25 years, so I don't know what it's like. I think since 2015, with the opioid epidemic, there's been a rethinking of behavioral self-management treatments. And so these types of treatments are like, well, maybe we should be kind of instituting them faster.
Well, I think the fact with all this information coming out on the gut-brain connection, I think more people are going to be open to it. And so hopefully we can find more practitioners like yourself soon.
Well, thanks to you, I'm sure that that's an important part of our, implementation efforts, is to making sure that people get the word out, and you're really helpful in that respect.
Yeah, that's kind of what I do in life, and I really enjoy bringing the information to the village, if you will. So, Dr. Lackner, what is the truth about GI health?
I think it's complicated, it's exciting, it's challenging, and it's, satisfying. That's, you know, that's about all.
That's great. Well, thank you so much. I really
Thank you
enjoyed
very
talking to you.
much. Thanks. You take care. Bye
Bye.
now.